Now, switching gears to relapse refractory disease, where we often divide these patients into two buckets, whether it's platinum sensitive based on 6 months of progression versus after 6 months, which will be, again, platinum sensitive initially if it's after, and if it is less than 6 months, then platinum resistant. Starting off with more of a simpler option, if it is beyond 6 months, yes, utilize platinum-based therapy.
Yep.
However, if it's less than 6 months, then NGS certainly plays a role with BRAF's V600E mutation, HER2 positive with recent bucket approval of TDXd in this setting, and also folate receptor alpha expressing tumor. How do you maneuver through all this, Martina?
It's very confusing. I mean, it's so nice to have options, but it also then makes it really challenging to know what to
Yes.
go to next. So the way that I interpret this, so you're right, platinum sensitive disease is a little bit easier, right? Because you just reuse platinum-based chemotherapy. This is a setting in which I usually will add bevacizumab. So that's fairly straightforward. For platinum-resistant disease, what I'm always doing in patients now at the time of diagnosis is testing for that folate receptor alpha. Again, in anticipation of the day in which they become platinum resistant, because most women with ovarian cancer will respond to platinum-based chemotherapy. Unfortunately, we also know that most women with ovarian cancer will have some type of a recurrence and with time will become platinum resistant. So I'm planning ahead for the future. So I am generally knowing, at the outset whether or not they're folate receptor positive. I will say that if they are, Mirvetuximab is my first choice if it's appropriate for the patient. And we can talk a little bit about that because that's another medicine that's not without its challenges to navigate. And the reason for that for me is that's the one that I think has the most data for overall survival benefit in platinum resistant settings. So that's my first go-to. And then if there is recurrence beyond that, then that's where I use some of these other, molecular markers or findings from NGS to guide my next move.
Can we take a little deeper dive here, Martina? Is there any overlap in number of patients that we see with folate receptor alpha and HER2 expression? If so, would you rely on Mirvetuximab or TDXd? Both are antibody-drug conjugate. And again, taking a pause here for a second, when we're talking about TDXd with its bucket approval, when we're looking at all comers, pancreatic cancer, even though it's approved as a bucket approval, had an overall response rate of just 4%.
Yeah.
But with something like ovarian cancer, it's 45%. We saw that in endometrial cancer, it's higher. It's like 55, 57%.
Yeah.
Mirvetuximab has overall survival benefit. How are you making those decisions?
So it's a great question. And again, I think if you ask different oncologists, they'd say something different. But I tend to, like I said before, I tend to use when I think about ovarian cancer, and I tell this to patients, I feel like I'm playing a long game once I get to the platinum resistant space. And so I want to be strategic in the use of the agents that I'm using. And so I tend to, like I said, use Elahere first if I'm able to. And then if they are HER2 positive, then that's another thing that I can use later. If they're MSI high or, deficient in mismatch repair, that's another option in my back pocket that I can use. So it really just kind of comes down to sequencing. And in my practice, probably related to the timing of approvals, I have just started using Elahere first. If I had a patient that had both of those as options, I would use, meaning the HER2 positivity and the folate receptor positivity, I would personally probably use the Elahere first, but it certainly wouldn't be wrong to do it the other way around.